Good evening, everyone. My name is Rob Hislop. I'm the ECMO and VAD manager at Children's Hospital, Colorado. Thank you so much for joining us this evening. This is our second quarterly iteration of a new effort that is being supported by ELSO within the ELSO community of holding quarterly symposiums. We call them coordinator symposiums, but they're certainly open to our community for all that wish to join. But we'll be focused on topic content each quarter that will be a little bit more specific to not only the clinical considerations, but the operational considerations and some of the impact of running ECMO programs. So with that said, just want to brush up on a little housekeeping business before I introduce the fellow moderators and panelists this evening. The intent of this discussion and these symposiums is to give coordinators and the ECMO community an opportunity to share a dialogue and to share an honest, open dialogue. ELSO as an organization is supportive of resourcing that dialogue, is very supportive of this community having that dialogue. With that said, what is discussed within these symposiums is not out of the mouth of ELSO. ELSO is helping us to launch the dialogue and to be able to have this conversation. But what the conversation that happens here is nothing more than every single center and coordinator's opinion that chooses to share their opinion here. That is so. One last housekeeping, a little bit unusual to what you might be comfortable with, or your past experience with some of the Zooms, is that the chat function is primarily an avenue if you are having technical difficulties, if you can't hear something. Essentially, the chat function will go to the ELSO organization that are helping to launch this webinar and some of the panelists. However, if you would like to put a question out for discussion for the group, where a normal chat may happen in a more traditional meeting, we ask that you put those comments, questions, or anything else in the Q&A on the far right at the bottom of your screen. So again, the chat for more technical issues, and the Q&A for issues that you would like to bring to the group, experiences that you've shared. As we launch into the dialogue portion of this program, we certainly, if someone would like to share something about their experience, we would have the opportunity to unmute and let you speak openly to the group. Okay, so with all of that said, let me handle some introductions. If we could forward to the next slide. Thank you so much. So we're doing a little bit different. We're doing a little bit different format this evening, in that we're inviting some people from outside the ECMO community in to share some of their experience. Because of this conversation with ethical considerations, moral distress, we all, are proficient ECMologists, and I would guess that very few of us profess ourselves to be experts in how to navigate these issues of the ethical side, of the impact on our teams of moral distress. And so the first speaker that we've invited to join us this evening is Phyllis Whitehead. Phyllis Whitehead is a clinical ethicist and clinical nurse specialist with Roanoke Memorial Hospital. So she will be sharing some of her experience as it relates to kind of interacting with the ECMO team there, and some of where from her perspective, some structural things that can be done to support frontline healthcare providers, especially in our environment. Our second guest this evening, who will be presenting, is Maria Young. Maria is actually an ECMO survivor. Maria was placed on ECMO at Johns Hopkins University out in Maryland. She spent 69 total days on ECMO and 130 total days in the hospital. And as a launching pad from that experience has launched a nonprofit called Maria's Miracles, where she helps to, or the goal of the organization, and I'll let her correct me as I'm mischaracterizing it, but where the primary goal of the organization is to support patients on ECMO, families of patients on ECMO, and anybody around the ECMO experience, including the care provider team. And then the last introductions for this evening, my co-moderators for the evening will be Evan Gajkowski, who is the ECMO coordinator at Geisinger Medical Center in Danville, Pennsylvania, and Shayna Amos, who is the adult ECMO and VAD coordinator at Grillian Clinic in Roanoke, Virginia. So with all of that being said, I will open the forum to Phyllis. Phyllis, if you want to share your slides and turn it over to you.
Thank you so much, Rob. Can everyone see my presentation? Great, thank you. It really is a pleasure to be with you tonight, and I always welcome the opportunity to talk about moral distress, and so thank you very, very much for the opportunity there. So I have no disclosures of conflict of interest related to this presentation. The objectives, hopefully you'll have a better understanding of how moral distress is defined, identify some sources of moral distress, and then we can discuss some strategies in helping mitigate moral distress. So the classic definition of moral distress occurred in the 80s. Jampton came up with a definition of when it was a negative response, when we know the ethically appropriate course of action, but we can't carry it out. Since then, we've added to that definition, and one of my dear mentors, Dr. Ann Hamrick, who I studied under, and hence she passed in 2019. But her definition I love, and to this day I really talk so much about it, but it's when our moral integrity has been seriously compromised, either because we're unable to act in our core values and obligations, or our attempts fail to achieve the desired outcome. And I like that because I think it just relates better. I think that sometimes, if you ask two different people what's the ethically right thing to do, we may come up with two different choices or a course of action. But when we start to talk about moral integrity and it feeling seriously compromised, that resonates. It makes sense to me, and particularly when our core values are in direct violation. So a little bit about the background. As I mentioned, Jampton was the first one to coin the construct, and it's mostly been studied up until probably about 15 years ago with nurses. It has expanded to all the disciplines now, including medicine, psychology, pharmacy, all the therapy, social work, you name it. It has expanded. And yes, the definition, I think there are more similarities than differences, although I think that the main differences occur with the imbalance of power. And I think we'll see why that holds true when we look at some of the sources. So be thinking about that imbalance of power and who has the most power and how could that come into play when you're unable to act in accordance with your moral compass. Here are a couple of sources of moral distress, and by no means is this exhaustive. It's not comprehensive, but I pulled these in because they really resonate with the consults that I've been doing and when I'm rounding on the ethics service and going out and about and talking to my nursing and other colleagues. And one of the big issues is really providing inadequate pain and symptom management when there's a lack of organizational support. How about this inadequate staffing? Does this resonate with a lot of folks? And I think everyone is struggling. And this was already a source of moral distress pre-pandemic, and boy, is it a huge source now, right? Working with incompetent clinicians, deception, bullying, here the power imbalance among the clinicians, as you can see. And my other hat that I wear as the clinical nurse specialist in palliative medicine, I see a lot of another source is aggressive treatment of the terminally ill when we feel as though the interventions become medically inappropriate or non-beneficial. And I think that this is especially pertinent with our topic this evening. So what compounds moral distress? Of course, the time constraints, most certainly, particularly with that staffing. Some things that I hear is, the electronic healthcare record, although I'm hearing it's really wonderful. I mean, we have it, but sometimes I sometimes want to throw it out too. I remember the old day of pen and paper. I think there's some really great components of it, but you can appreciate that it leads to less face-to-face interventions, and people are it's more checklist versus some of the critical thinking documentation that we had in the past. Legal implications. Are we concerned that we're going to get sued? And that's why we're not doing the ethically and morally appropriate thing. Of course, we talk about the pandemic, and a big part of it during this entire time during the pandemic was justice, when we talked about the greater good of society versus individual rights, autonomy, and them being in complete contrast to one another. Once again, with my being a clinical ethicist, I'm not saying there's either extreme, it's a combination, right? But it's quite interesting where the pandemic really, they came in direct contrast there. And then we talk about hierarchy. How is the hierarchy in healthcare? How's the hierarchy in nursing? What's the hierarchy in medicine and administration and on, and who has the highest level of power? And how does that impact the decisions that we make? Once again, communication, and I don't know what you guys have seen, but my experience, and I labeled it as microaggression, and sometimes it's just flat out aggression, right? Among patients, families, visitors, among other staff and other teams. And it's not just in healthcare, right? It's everywhere we go. Unfortunately, we're also seeing more aggression and violence, right? With just last week where we saw a patient targeting a physician, right? And the shooting. So it's certainly there. When we talk about that hostile work environment, this certainly leads to that. I think we're going to see more and more of this, as we continue to struggle, and I know I struggle with it on a daily basis. How do I maintain a positive outlook? How do I continue to do the right thing, evidence-based? How do I, and quite frankly, I'm tired. Are you guys tired? I'm tired. And it's, I was maybe tired before the pandemic, but I'm really exhausted now. And so when you're tired, your threshold is harder to be able to, rebound. And we talk about resilience. And of course, if I hear one more thing about resilience, I might scream a little myself. And it's not that I don't think we should be resilient. I just think it's really hard when you're compounded day after day, shift after shift with these same variables. Expectations, I think, unrealistic and realistic. I mean, sometimes, as we can see here, families can be unrelenting. And same thing about staffing, right? That can be unrelenting too, about how do we maintain, how do we have safe staffing matrices. Another thing that we saw, especially it came out very clear over the pandemic, is death and the dealing with dying over and over again and watching people die, particularly with COVID in the earlier days, right? And I know that some of the COVID units that I worked with and took care of patients on, it was just like, I didn't go into this to see this much death, right? And it was the exception, not the norm, that people lived. And then, of course, I think we have to be aware of our own implicit biases, and we all have biases. It's not that, well, we just need to be more aware of them and to be transparent and be able to talk about them. I included this blog because it just really resonates with me. And I came across it in 2008, and it was in the New York Times, and it was from a physician. But I think we can just, where it's physician, I think we can say nursing. I feel so conflicted on a daily basis, almost compelled at how my profession, how can, and we'll say nursing, practice when it is run by financial interests. How can I help anyone who I don't know? I'm not allowed to spend the time I need to with my patients. And yes, I've become a machine. What happens when the patient's best interest is not in the patient's best interest, but to avoid a lawsuit? After all these years, I know that the patient-nurse relationship is the most important thing, but current policies, practices, and dynamics do not allow for such a thing to exist. I don't know, this just, unfortunately, I think I see more and more folks along the lines thinking this way and hearing it. And I think healthcare has forever changed the landscape since the pandemic. So what's the impact of moral distress? Why do we care? What's the so what factor? Well, certainly it can lead to burnout. It can also lead to folks leaving the position, the actual position that they're in, but also the profession when folks have left the profession. It can, when you are triggered by certain similar situations, sources of moral distress, you can avoid patient interaction altogether. It can place blame on administrators and coworkers, and feelings of powerlessness, helplessness, low self-esteem, guilt, and anger most certainly can occur. So some key features that I wanted to go over quickly is that most certainly it's subjective and it's not the same for each of us. And if we're all experienced the same situation, we're going to come out feeling a different level of moral distress. Some of us may not feel any moral distress. Some of us may only have a little, and others may really, it just resonates. And it's because of those experiences, because of our, once again, we're going back to our core values and obligations, and they vary a little bit. Now, there's the difference between our professional obligations, and yes, we have those similar obligations, but because of our experiences and who we are and how we have trained and integrated into our personal values, it does vary. And so it's not right or wrong. I'm always happy when someone isn't experiencing moral distress. But I don't want us to shame or blame individuals who are experiencing moral distress that differently than each other. We talked about that power differential and that feelings of powerlessness. And this is going to be really important as we get into talking about some strategies, because it's really important. How do we start to move away from feeling so powerless? And that's key. And we've already talked a little bit about there's such can be very, very strong negative emotions. And I think one of the biggest issues is regret, and that there's residue. So even after the morally distressing situation goes away, and yes, our moral distress levels may lessen, they never go away. And then there's this residue. So we never get back to our baseline. We never get back to, ground zero, right? We're never there back. And then when we have similar situations, we just, the residue is there, and then we have this reactive distress, right? And that's what I think is important that we keep in mind. So when we say, okay, well, that patient's done, and so we can just go on back and not deal with it, we still need to deal with the situation, the damage that's occurred, the distress, the trauma that has occurred. The Crescendo Effect is a phenomenon that really talks about how that moral residue builds over time, and that it still, even though it may come down a little bit, never goes back to that zero level. And we know that similar situations will trigger you, and you will be right back in the thick of it. And I think you can probably think of some of those situations that, yeah, they're not where they were, the current situation, not as distressful potentially as the other situation or situations, but you're feeling it, it's all accumulating. And this is a model that Epstein and Hamrick that came out in 2009, both of my colleagues, my research colleagues. So differentiating, I can't speak this evening, sorry. Moral distress, it is different than emotional distress. And I think sometimes folks get those confused. Of course, all of moral distress is emotionally distressing, but not all of emotional distress is moral distress. And so it has to really have that compromising your moral integrity piece of it, and that going in odds of your core obligations and values. So how can we, some of the factors internally, and I don't want to spend a lot of issues about the internal, each of us, but just knowing that it's subjective, and that, how we are, how we internalize, how do we think through, how do we process situations, our confidence, some of the other issues, if we're someone who's more timid, someone who is more an introvert than an extrovert, can come into play. What I'm really interested in are the external factors that that confront us. And this is where I think it's such a great opportunity when we look at institutional constraints, because when we're seeing the institutional constraint, there's a possibly we can make a difference, right? We can, once we identify them, then we can actually create a strategy, a plan that can work through that. Now, not always, right? Poof, we can't make more staff, right, immediately, but we can start working on some of the issues. So those are a couple of these. And then I wanted to talk a little bit about what can we do? So what are the actions? When we are confronted and we feel as though we have a properly identified moral distress, I think one of the biggest issues is being able to get all the information, get the whole story. We hear over and over again, it's important to be able to speak up and encourage a dialogue. And if it seems risky or you're worried about retribution, that's the first problem to tackle. It's a red flag, because we should be able to ask questions, right? And then I love these 4 questions that I use all the time, is what ought we be doing, right? And what is our primary obligation? Because sometimes we have multiple and sometimes obligations, and sometimes they're conflicting, right? What are the goals of care? And also to recognize that just because that's how it was doesn't mean that they aren't going to be changing. So I love this framework, and I'm glad that you're going to have access to, and I'm happy to share my PowerPoint so you'll be able to, jot these questions down and to use them in your practice. And do they need to change? Just define one. So then once you get, we debriefing the situation, I think, with the goal of, if it's already, in the past, we can use this as an opportunity to prevent it from happening in the future. If it's currently in the present and it's happening now, we can use it as an opportunity to say, okay, what can we change now in the moment? And I think that is a really great approach, because once again, that starts to shift that powerlessness and helplessness into action. And I think it's important to make certain that we include the entire team, including physicians. My most powerful strategies and interventions involve the physicians, so that folks can hear one another, and that we recognize that we are all in this together, and that they are also experiencing moral distress, even as hard as it is for them to admit it. And then most certainly being able to have interprofessional education on moral distress, like you're doing tonight, right? Learning more about it and being able to identify it. I think also being able to have clear expectations of what collaboration and teamwork for your team, your unit, your service, and being able, and some of the things that can increase that, of course, and looking at what's working well for your unit and service versus what are some opportunities, like, is there something that we can improve upon with the interprofessional rounds? Do we need to create some opportunities for unit or service conferences? If it's directly with patients and or their family, scheduling a family meeting so that we can get on some common ground and have clear expectations. At the system level as well, I think it's important to be able to have, and if you don't currently have, to have policies and processes in place that will encourage that communication and that teamwork, and also to be able to, if possible, consistent messaging, right? So that I love this, the team speaks with one voice. And how many times I see this over and over, is like everyone's kind of chattering, but no one's really on the same page, right? So much of this specialties, we get siloed, and so it's hard to get the bigger pictures many times. And then, of course, making certain that, okay, maybe you have wonderful resources available at your institution, but are they known? Are they available, and are they sanctioned? So many times it's like, I had no idea we had this, or X, Y, or Z. And how do you address the moral distress? I mean, most certainly you ask whether, first of all, you're feeling it, affirm the feelings around the issue, assess the facts, what is the source, what is the right action, and try to come up with an action plan. And then we talked a little bit about the policies and procedures. I think being able to pull in your leadership teams, and I know you are leaders within your organization, and working with other leaders and your teams to be able to create the policies and that safe space to be able to come together and talk about it. And of course, then it may be that it's not just a specific area, but maybe it's multiple areas within your organization, and making certain that those resources are available in the system-wide. And we've already talked a little bit about this. I'm just going to reiterate it again. Speaking up and identifying the problem, voice your opinion, make certain that you're being deliberate and to know who and what you need to speak to and about. Also being accountable, right? Being professional and respectful as you're speaking up. The focus is on improvement of the work environment. It's not shaming and blaming individuals, but really looking at more of a system level or team level, not an individual level. Looking at making it a team sport, right? That you want as many of the disciplines as possible. You want to be able to articulate the root source or cause. And you certainly want to make certain that as an individual that you're taking care of yourself as much as possible. And I've moved away from the term self-care, but more, I like the term self-stewardship. Just like we're good stewards of resources, we should be good stewards of each of our own selves. And most certainly to be detailed and being articulate in what your asks are. Now, at our institution at Carillion Clinic, we have a defined moral distress consult service that I started as part of my moral distress research. We were the second in the nation to have a formal moral distress consult. And I am, how did I make it happen? I just kept coming, and I was persistent. And they finally, I think, just said, okay, Phyllis, all right, I give up. You win. But it worked. And it's under our ethics service, because this is an ethical principles grounded in ethics. And so it allows for staff to come together with the common issue of the stressor, to talk as a team, right? To have that frank, honest conversation, and then to come up with strategies to address why, what are the barriers? What are the things that we can do? And it really is just an environment to empower staff to raise their concerns. And this is just a summary of, we talk about the situation, if it's a patient situation, and usually it is, but it doesn't have to be. We identify the sources of the moral distress for this particular situation, and then we talk about and we identify, and this is where the most powerful piece of it in my mind, it's the right actions. What are the strategies? What can we do about it? Once again, shifting away from feeling powerless and helpless into action. And that, in a very quick nutshell, is my presentation, and I will look forward to answering any questions after our next speaker. Thank you, guys. I'm going to stop sharing.
Thank you so much, Phyllis. Greatly appreciated. Well, Maria takes the opportunity to put her slides up. I do want to just kind of frame the rest of the agenda for our discussion here. After Maria has an opportunity to present her experience, and both of these, I view these as, framing of kind of some of the concepts that we can consider as we have this conversation. But the largest goal of this symposium is to help us think about ways that we can put into place and operationalize fundamental or tangible things that help our teams, right? And so after Maria has an opportunity to present, we'll open up for both questions of Maria and of Phyllis. And then also, like, as I would love to hear if people have had some success in putting into place systems that are helpful in supporting their teams. I think that everyone in the ECMO community, and it's not just COVID, it's just in the long-term nature of what we do and the mortality and morbidity that we see on a daily basis. And so I would love to hear from all of you if your program has been able to put something in place that really works well. So I encourage you to put either of those in the Q&A, and with that, I will turn it over to Maria.
Thank you so much for having me. I just wanted to start out by thanking all of you. This has been an incredibly hard 2 years, I'm sure, more than 2 years for each and every one of you. And coming from the survivor end, I thank you all for the work that you've done over the last few years. That being said, my name is Maria Young, and I am a severe COVID-19 ECMO survivor. This is a photo of me in mid-January of 2021, after I had spent a long time hospitalized and over 60 days on ECMO. I also spent 70 days on a ventilator at Johns Hopkins. So I wanted to share a little bit about my story with all of you, and then take a little bit of a different perspective on caregiver distress, and kind of from the family perspective and from the patient perspective. And at the end, I want to share with you a little bit about what the nonprofit that I've started has been doing. So just to get us started, let me change the slide. So before COVID, I lived a really active life. I was 41. I did yoga and military style boot camp. I was actually usually on the other end of events like this, and I'm a meeting planner. I helped then Vice President Joe Biden on his Cancer Moonshot Summit. So I was in the health space, just in a very different, little did I know what the universe was setting me up for. So in October of 2020, I started developing COVID symptoms. This kind of series of events is nothing new to all of you, but I was admitted to the hospital after calling the ambulance on myself with an oxygen of 40%, where I was immediately placed on BiPAP and spent the next 12 days at a local hospital, sort of fighting for my life and the treatment that I needed. On the night of November 13th, I was intubated and transferred to Johns Hopkins Hospital, where I was immediately placed on VV ECMO. So these are a list of some of the challenges I faced while hospitalized on ECMO. You've seen all these before, I'm sure. When I woke up, I went through pretty severe drug withdrawal, delirium, isolation, and I really had to relearn how to do a lot of my daily tasks. And I was at a time when the hospitals were locked down, so my family didn't get to see me for over 3 months. And when I woke up and was recovering, I could only have one visitor a week. So it was a tough time for the hospital caregivers and my medical team, as well as my family and community at home. One of the challenges that my family faced was that when I was in the hospital, I was a 41-year-old that had not established a health advocate or a proxy. So while I was going through some pretty severe hypoxia in the hospital and declining a ventilator, my family wasn't being kept informed, and they were being given very limited information about what was happening to me inside the hospital. And I was allowed to make medical decisions that truly weren't in my best interest. I had also said I didn't want to go to Johns Hopkins Hospital for ECMO. So, it just shows like what, lack of oxygen and what kind of decisions we were being allowed to make at that time, because we didn't quite know any better and didn't really know how to handle patients like me. So this is where I want to pivot the conversation a little bit and talk about kind of the role of the caregiver from a family perspective, and what what my caregiver network looked like and how that impacted how the communication kind of flowed between my medical team at Hopkins and my family. So when I think about caregiver community, I'm looking a little bit differently, not necessarily at the medical community, but also family, close friends, extended family, friends, coworkers, neighbors. And also, like, for me, it became this really huge community of support and caregivers that wanted to help and do things. And obviously, I also had this incredible medical team at Johns Hopkins that was kind of interacting with some of these levels in different ways. So I'm going to talk a little bit about how my family interacted with my caregivers and how that dynamic was, as well as some of these other groups. So my family was really the ones having the hard conversations with the palliative care team at Hopkins, as well as my doctors and a lot of my other care team. We had ECMO, the coordinator was on the call sometimes, organ donation was on the call, and these were pretty tough conversations to be having. It caused really strained relationships within my family dynamic. And it also, they were making some pretty tough decisions and having some really hard conversations. And one thing I want to just express is that these are highly emotional people that are listening to these conversations. And what we noticed, or my family noticed, and my close friends noticed, was that when the care team at Hopkins was calling my family, my mom was kind of translating down the line, and she was hearing something very different than what was being told to her. So the information she was passing along, it was almost like a game of telephone, where by the time it got to my dad or to my sister, the information had been diluted a little bit based on her emotional state. So one of my friends recommended establishing a weekly Zoom meeting with my care team at Hopkins. And that really helped sort of level set and make sure everybody was hearing the same message at the same time. And it also helped my care team at Hopkins to be able to really discuss what was happening with the whole group and establish the path forward for everybody. And my family also, with the help of my medical team and palliative care, really stepped in and kind of helped guide my family, was to establish a flow of updates throughout my community. Everybody wanted to know a lot of details, and it was very difficult when different people were calling the hospital. I know that puts a lot of undue burden on medical staff when they're short-staffed. Things were very busy. And also they recommended establishing a list of ways sort of our extended community could help, which was really helpful. And my family turned to social media and virtual support groups for help. There's some good ones out there for families, and I'll talk a little bit more about that further on. So my close friends were given a seat at a table that they didn't really want to be at. They were asked to give input about what I would think, how I would feel about things like a DNR. They were in the conversations with palliative care. They were asking, really hard questions and talking about organ donation and that sort of thing. And for all these groups, there are very few family focused resources about ECMO and what comes next and what really the progression of ECMO is. So my close friends were given kind of direct tasks by my family. Can you do this? Can you do that? Can you communicate with this group? And that really helped them feel like they were part of my care team and my care community. And we also have this network of extended families, friends, coworkers. They all wanted to be kept informed as well. So for my family to be able to take the information from my care team down the road, they established a Facebook group with updates. They also created a messaging system on VidDay that my care team got to play for me when I was on ECMO. And it kind of brought them a little closer to me. They got to know me a little bit, my family and my group, and they laughed with my family. They cried with my family during these messages, but it was a way for my community to feel connected and for my care team to get to know who I was a little bit. They also started a meal train, which gave them some purpose and something that they wanted some way to help. So all that being said, when I started recovering, I started thinking about, hold on one second. I think it's different. I changed the slides a little bit. But one of the main concerns with my family was, what was my neurological state going to be like when I woke up, if I woke up? And they were happy to see my first social media post was was reassuring that my sense of humor had not gone anywhere and that I was still the same me, and I had a long recovery coming, but I was Maria, and I still had my sarcasm and sense of humor. So through fighting through all this, I wanted to be able to help the next miracle, the next Maria, and help my care team at Hopkins take care of the next group of people, have access to resources that are helpful for the Hopkins team and other ECMO coordinators and ECMO teams across the country to have somewhere to send families, to take the burden off of the care team, the medical care team a little bit, by being able to send them somewhere that had valuable, legitimate, confirmed resources that were good, that were from legitimate sources. So a little bit ago, I established a nonprofit called Maria's Miracle, and we have a couple of different goals. Our mission is to reduce gaps in access to critical care across the country. We're hoping to establish a fellowship at Johns Hopkins Hospital to train in heart, lung, and blood critical care at Johns Hopkins, as well as ECMO with the team that took care of me. So we're working on that. That's one of our big goals, but also to provide families with resources on navigating ECMO and long ICU stays. Some of the conversations that I've had with family and ECMO patients over the last year, they ask a lot of the same questions. They want to know, how did I feel about my family signing a DNR? What was ICU delirium like? And I got asked the same question so many times. I started thinking, like, we need to put this somewhere. Like, we need to have a resource for these families so they have a place to go and they don't have to kind of wonder about these questions. And I also am working on creating a community of survivors and experts to support these journeys, to share their stories, to share their challenges. A lot of us have similar stories, but there's also different elements, and we've all experienced a little bit of a different aspect. And all of this really helps the medical care team care better for the patient and families by giving them this type of resources to reference. And some of the things we're working on too is a glossary of terms. There's lots of acronyms when you're talking about ECMO and an ICU stay and a medical journey. So we've put together a glossary of terms that is in pretty plain language. So families who are very emotional and not really hearing things correctly can reference and understand some of the terms being thrown around. And we are also working on let me see, hold on. Anyways, so there's a book list on the website, on my website. There is a list of virtual support groups for families and caregivers and different target audiences, which are really great. And we welcome other resources that you found helpful for your families and your communities. And we're happy to add those to our website so that families can have access to them. Some of the silver lining, I think, for me is that I've really been able to connect with my care team at Hopkins after my journey. When I went back into the hospital 2 months after leaving, my CV SICU team said nobody ever comes back to see us. And part of that we know is that not many of us make it out the door, unfortunately, but it's been really such an experience for me to connect with the people that took care of me. And I go back every couple of months to see them. And a lot of them have joined me on this nonprofit journey and have asked to be part of the board and part of kind of this journey that I've taken to help other ECMO families. So we get together every couple of months. We have a lot of fun. We've been able to smile and laugh kind of throughout the last year of my recovery. So these are some of them, some of my nurses, caregivers, the ECMO, head of medical ECMO at Hopkins is on my board. He's pretty amazing and has become a great friend of mine. So I'm incredibly lucky that they're with me along on this journey. And we invite you to follow us, to come along with us on this journey of collecting stories and resources for families. And I've sort of opened up my story to everybody. I answer every question. I am very open about my journey and what happens before ECMO, during ECMO, and after. I didn't have anybody to ask questions to, and I feel like that's an important part of this community, is to have people like me speak out about what the experience is like. So thank you, and that's kind of all I have.
Thank you so much, Maria. Greatly appreciated. So like I said before, I'll bring in both Evan and Shayna to the conversation, who will kind of help ponderate the rest of the discussion here. We would very much like to hear from you, both questions that you may have from our panelists, and especially if you have in your own experience, or if you've heard of structures that are working well to support your teams in these ways. And let me just pause to let Evan and Shayna kind of add anything to that framing of the discussion.
Thanks, Rob. And thank you, Maria, for talking and sharing your story. I think one of the things I had asked you, Maria, when I had first connected with you, I exclaimed how surprised I was. You have some videos on your website where you have other ECMO survivors you're talking to, but you also have a large group of caregivers that attend some of those meetings, and you've talked to before, and they've reviewed your case, and you brought some of the caregivers to tears sometimes in that video. And that was the first time I have seen anything like that. And it caught me off guard to say, like, there's a connection, like, you know, there's the patients and there's their care groups, and then there's the providers and their care groups. There's no reason why we shouldn't all be talking to the same thing, because we're going through the same things together. And your care team had the same things to say as you did. Your one doctor had said, were we crazy to think going in you had no tidal volumes on week 6? Were we crazy to think you were not let off paralytics in 5-6 weeks? You know, why were we thinking this? Were we crazy to do these things? And it brought them emotional. And we wrestle with those things every day in clinical, and sometimes we have to teach ourselves to shut it off when we try to go home. So I think I'm kind of rambling a little bit now, but I think I just wanted to say you are definitely onto something here with combining the patient and the caregivers, and how can we better bridge that gap together with our patients, and what you do. And so how are some of the things that we can do to help our mental health as well as our patients kind of at the same time?
If I can just add on to that, I think I wanted you guys to see what you fought for the last couple of years. And I think that was really important for me. And some of my caregivers were actually really resistant to it. I don't think this is the normal course of a relationship. Some of my nurses said, you know, we get you off the brink of death and we kind of pass you off to the next team, and they don't connect with you afterwards. And I really have made a point of going back and finding people that took care of me that I remember, because again, this has been such a crazy couple of years that none of us would have expected to live through. And I think it helped their mental health and their, you know, desire to keep doing this by making those connections. So I encourage you. I know it's not always comfortable and it's not something we're used to, but I think it's really important for us to keep that relationship going.
Yeah. I think that we have, before the pandemic, we had these questions come up because we had a lot of readmissions with some of our ECMO patients. And really it was a lot of PTSD, depression, anxiety, and then not taking their meds and kind of falling by the wayside. So we had started a post-ECMO clinic. And so we get to see our patients and we create bonds with them, and I see them, and mostly it's just a kind of little bit of take credit that I don't deserve. But we make sure we follow up with them, and the ICU psychologists now, their team has expanded to see those patients, and we even refer our staff. I think you had said, you know, this is not of the norm to see patients go 6, 7, 8 weeks on ECMO. before, if you got to day 14 and you didn't have any lung function and you had H1N1 influenza or some type of pneumonia and your lungs weren't working and you weren't a transplant candidate, we were going in and shutting that machine off, and we were having a discussion with the family. And now we're taking it to, you know, like your doctor said, 4 weeks, 6 weeks, 7 weeks, 8 weeks. We just keep going. And I think mentally it's very difficult to take care of those patients and the families as the days go on. So we had started a RISE program for our nurses, and to talk with some, and so counselors come in on each shifts, bring individuals in one by one and let them kind of open up a little bit and give them a break on the floor. And sometimes it's extremely busy, but we have these psychologists that come in and talk to them. And I think I use them all the time too. I'll go in and sit down, have a cup of coffee with them and just kind of vent. And it's very helpful. And I think you have to get those things off of your chest so you can clear your mind and then go back out there and take care of those patients to the best of your ability. Because as Phyllis had said, if you don't do those things, then you start to retract and not do your best care, and you're not engaged with the patients, and you're not doing the things that you need to do to improve their quality, to try to get them better. But I think so too. You got to get out of that comfort zone and just be like, hey, you know what? It's okay to have a connection with some of your patients. I guess as long as you don't have too close of a connection, as long as you have some formal connection with them in these support groups, it's okay. And it's okay to feel uncomfortable to do those things. So just some of the questions to go through here. Shayna, do you have anything to add with on Phyllis's talk or for Maria's before I go ahead and answer some questions?
I'll just kind of punt this question to Phyllis, and I've, she and I have actually spoken about this before. I think being an ECMO coordinator is a unique position because you're a leader, but you're also kind of a part of the team as well. Most ECMO coordinators are also specialists at the bedside running pump as well. So we're kind of in the muck with everybody, where you have a lot of structures where the leadership is not necessarily in it on the day-to-day, but we're also expected as leaders to be able to sort of pull people out as we go along. So my question and my struggle has always been how to sort of recognize moral distress or emotional distress in staff members, and mitigate that ahead of time. I think it's always been there, but the pandemic made it worse. I know we're all sick of talking about the pandemic, but it is what it is. When we're kind of in it with them. So sometimes it's hard to see the forest through the trees, I guess is what I'm kind of trying to say. But what are some advice you would give to coordinators as leaders of the team to kind of see maybe what the specialists can't see or can't bring themselves to mitigate on their own behalf?
It's a great question, and physician heal thyself, right? It's one of those things where we're caregivers, and it's hard for us to, first of all, admit that we're struggling. I think there's a lot of this across the gamut, not only for moral distress, and we talked a little bit about burnout, we talked about, and we hit upon so many topics, compassion fatigue, right? But also the other aspects I think we hit upon is depression and anxiety and some of the mental health challenges that we're confronted with, right? So I think part of it is I would encourage each of us to speak up. But I also speak up not only about what we're feeling, but if we see a colleague who's struggling, that we reach out and that we show our concern and talk to them. And just like you said, these are hard conversations. Many a times with moral distress, I will say that it's usually not unique to one individual. These are usually situations or sources that multiple folks are experiencing. And so to a certain degree, what happened with the pandemic, which really took away a huge part of the strategies and support system, is each other, right? The pandemic, we weren't able to get together. And I know that's improving some, but it's still not the same. Like we had potlucks, right? And you came together and you were able to talk, or you had a drink outside of work, or non-alcoholic, of course. I mean, but had that drink, or we had that picnic or that gathering. And the pandemic really did take that away from us. And over and over again, what I heard was, the biggest way of mitigating my moral distress, my colleagues, is to support. And I don't have that anymore. Now it's a different work environment. It's opening up, we're able to do that. But now so many folks, so many of our friends and colleagues have moved on to other positions. And so there's a lot of travelers, there's not that connectiveness that we've seen in the past. So I think one of the things is that if you're feeling it, then it's just like anything, then everyone else is feeling it, and being able to just set aside some time to talk about it. And like I said, if you have, I love the counselors. I love that, Evan. I love that you have folks coming. I think that's really important, that we start to normalize it, and not it becomes just integrated into our practice, that you don't have to ask. And so it's not that burdens on our shoulders individually alone, but that it's built into the team and staffing. So kudos to you. I love that idea. And for our organization, as Shannon, we've talked about, moral distress consults, right? To be able to have that, to be able to have, our chaplains are a huge resource, kind of thinking through what are those resources that you have at your institutions, and those really skilled clinicians, counselors, chaplains, social workers that you can talk it through. But I think the other thing is one another, and really trying to restore some of those pre-pandemic social activities that we used to do. And it's grounded in the literature, in the science and evidence that makes a huge difference when we can support one another.
For institutions that maybe do not have the same setup system of ours with moral distress and counselors and whatnot, what kind of resources would you point them to kind of get started, or to build that kind of service?
Yeah, I mean, so I think that we have created, I'm part of a moral distress coalition that's comprised of different organizations throughout the nation. So I think that one of the things, it is grounded in ethics. I would love to be able to talk to you offline. So if you're interested in learning more about starting a moral distress consultation service and working, with your ethics, and how do you build that stakeholder, how do you create change within your system, please reach out to me. I'm happy. I can actually drop my email address in the chat box. Maybe I can type and talk at the same time, not always, but sometimes. And I would love to hear from you. But I think that's the main thing, is to kind of taking a look and seeing, reaching out. There is a little bit of research out there, a lot on moral distress, not many on the consultation service. I'm writing a paper that will be coming out soon about the merits of why you need a moral distress consult service for your institution.
Thank you.
You're welcome.
Can I just chip in real quick? Marcia Zinger had a really interesting comment on the chat that herself and other members of her team do a lot of following patients through to discharge, and then if it was an unfavorable outcome, kind of grieving with the patient's family. And I know that there's a lot of other perspectives that we should have walls, and I know for my own team, we have a lot of type A people that have their walls pretty high, but so there's certainly some different dynamics, and I was just wondering, both Maria and Phyllis, kind of what your perspective on that is, as far as the pros and cons of getting too close, or the value of getting too close.
Well, I think that's a great question. I think that each of us have our own level of comfort. I think that being able to that it's connectiveness, I think, is really important. And Maria, you talked about beautifully, much more eloquently than I, of how there's a bond, and not only for the patient and families, for us, but also that we've been we're really bearing witness to probably some of the worst days of your life, right? And there's just something, there's a connection. Working in palliative medicine, also is my other part of my job. I see that. And I think it's just really important for us to allow ourselves that there are certain folks that we're going to get closer to that just really, we touch our hearts, right? They just do. Not everyone. I mean, we're all a little different. And it is okay, I think, to allow yourself to grieve. I think it's important, and not to deny us. And I never I was taught, been in nursing way too many decades than I care to admit, but I was taught you got to be tough, and nope, don't show your emotions, and nope. And I think that was the worst advice ever. I think that when it's okay to be emotional, as long as then the attention doesn't go away and the patient and the family's comforting you, then we've taken it too far. But I do think it's important to be able to have that balance, and it means a lot to our patients and families that you care. It matters, and that you're happy or you're sad, or when things are happening. And I think that's the human connectedness that we lost so much from the pandemic, and we need to reestablish. And I think that's why we're seeing such a soaring of mental health illness in our country, and suicide among healthcare clinicians and adults and even children. I was on a call because mental health is another one of my areas of interest, and kids as young as kindergarten thinking suicidal ideations, and it's because of the pandemic. And not being able to do that. So there is something, we are meant to have connection. And I do think that whatever your level of comfort, but I think it's normal and can be therapeutic.
Yeah, Marcia had said, and maybe PEDS is different as a coordinator, they follow through with their patients on discharge. Yeah, I think with neonatal, and Rob can even answer this, being specifically a neonatal pediatric hospital. Sure, I'm sure that the neo kids and the pediatric kids follow closely with their PCPs, neuro, whatever pulmonary cardiology that they would need to follow up with. And sometimes our adult patients, especially where I live, it's a very rural community where we'll pull patients from about 2.5, 3 hours away. That's not uncommon to have people travel that far just to get where we are here. But Rob, anything to add to that for the neonatal pediatric patients, a little bit closer of a follow-up for them?
No, I think that I think the dynamics are still the same. And Marcia, please chip in if you I would like to hear your perspective on what's being said here. But I think that there's certainly the family dynamic. Like emotions are probably heightened in the pediatric world, and like my own personal mechanism for resilience over a decade of doing this is to be sure to celebrate, take stock of the successes, because where we don't have the outcomes that we would like to achieve, those are going to be hard in the pediatric world. And then you have the grieving family, which is not to say that adults don't grieve, but I think that just the nature of that grief can be a little bit different when we're talking a newborn. So I think the dynamics I think it's a little bit different, but I think that I would guess that the nature of all of this is similar to what is experienced in the adult world. Having said that, I really worked my entire career in pediatrics, so just as you can't speak to my world likewise.
One other thing to just kind of touch on is during the pandemic, and Phyllis and Maria can maybe help us with this one. I felt as though as a healthcare provider, I would speak out and do marketing for my hospital on the importance of vaccination and wearing a mask and social distancing, et cetera, and how I'm fortunate enough to my wife and my brother and then his wife are nurses as well. So we all kind of banded together and did some marketing and stuff and said, you should get vaccinated and talk to our our other neighbors and family members the importance of vaccination. And I had received a lot of social media backlash to I don't have social media anymore, but my wife would receive comments about, such and such, your husband's wrong, you should read this, et cetera, et cetera. And it was just very difficult that in the hospital, we had one conversation. These are COVID patients, we're unvaccinated, the sickest. I don't think I got a consult that was a vaccinated patient. And so it was very difficult for us as a team to process in the hospital these patients super sick on death's door, a super long time in the hospital, 50% chance of recovering. And then outside we would go and be at this store, and we would be wearing our masks and kind of being ridiculed for it. And I just wanted to see, have you guys tried, or what have you guys done to try to mitigate that or continue on the course of speaking the right things and how to mitigate those processes?
I think I had to have a really hard conversation with myself when, so I was pre-vaccine. When I was, sedated, there were no vaccines. And when I woke up, we had 3. So I was, exactly at that moment. And I've spoken out about vaccinations after I got vaccinated as soon as I could. But I'm sitting on a advocacy advisory board for Novavax now, and I was talking to them just the other day, and they said that the percentage of anti-vaxxers for any vaccine used to be 10%. We're now looking at a 30% anti-vax. Just that's 3 times what we used to fight. Now we're fighting a much bigger population that doesn't want to get vaccinated, and vaccinations in general are at an all-time low for children. Even the common vaccines that we've had around for years, and there's a real danger to that. So I do speak out, but I have a tough skin. Not everyone has tough skin, and I've had some really difficult conversations with myself and with other people. But I had to decide, can I help people who have chosen not to be vaccinated? Because we all know there came a point where most of the people that ended up on ECMO were unvaccinated. And I decided, yes, that I could, but I do try to have gentle conversations with the family about vaccinations when it's appropriate. Because I think when you've gone through something like this, you can't imagine somebody not taking every precaution that they can to avoid something like this.
Maria, I commend you. I think it's been really hard, and unfortunately, I think that, not to get political, but it's been politicized, right? So it's along the party line many times, and a mistrust, and I always hate that, a disbelief. And I think what I see over and over again of folks that maybe chose not to believe, and then all of a sudden, when they became infected with COVID, they had a very different perspective. I will personally share that my mom died from COVID just this January. And there's a lot of issues in and out of that. But she was elderly and had a lot of other immunocompromised issues, but it is. And I think it is important for us, and I think to tell our stories. And I think that people will choose to believe or not to believe, but it doesn't mean that we still don't continue to speak up and to tell our truths. And I just think that is incredibly important. I hate, Evan, that you had backlash for doing the right thing. And I think that was the trauma that we experienced, that we went from being heroes to being, villains, right? And, and we were, oh my gosh, we were the enemy of the state. And so that's a hard thing to swallow and to be able to cope with. So it's going to be very interesting as we move forward. Hopefully I think there's that whole ethical principle of justice, and I think that is very important. I am very much a huge fan of autonomy. And let's keep in mind, the United States was formed on the principle of rebelling. And so it's another example of, I'm not sure how united we are in the United States, but these are some strong principles. So we just keep telling our truths.
Thank you. Shayna, anything to add there for our team?
No, I just want to thank both the speakers for coming and sharing their presentations. I enjoyed both of them greatly. And like Phyllis said, just keep fighting the good fight.
Yeah, I think it's important to make connections, speak out, vent when you have to, and to not keep things in because they just continue to build up. You know, there's help out there, and if there's not, then we can join together and help each other.
All right. Thank you. Thank you, everyone. Thank you, Phyllis. Thank you, Maria, Evan, and Shana. Thank you for all of those that participated, chat and whatnot. Really appreciate. I really appreciated the conversation. I don't know how. I think now is a good time to recap that. This is that ELSO is in full support of supporting their coordinators and having these discussions. And that none of this is official. Nothing that you heard this evening, especially on something that's so kind of personal and has so many, personalized aspects of it. That this is not official ELSO company line on any of this. This is an opportunity for all of us to discuss amongst ourselves while they support your programs and the ability to have this conversation. Our third quarter symposium will happen during the ELSO conference in Boston. That will take place in person only. I've been told that there's some real challenges with doing a hybrid model between in person and online at the same time. And so we will be, we hope to see everyone in person. We hope to have a nice, robust conversation in person. That's going to be a little bit more tailored toward the technology aspect of our jobs and some of the, the technology or new product to market and thoughts about cannulation strategies and ways to support patients and whatnot. So look forward to that discussion. Before I kind of close up, does anyone have anything else to add this evening? Okay, excellent. Well, thank you so much, everyone, for joining. Greatly appreciated. Again, thank you so much, Phyllis. Thank you so much, Maria, Evan, and Shana for helping to facilitate this discussion this evening. Have a wonderful evening, everyone.
Thank you.
Thanks, guys. Bye.